Hello, good morning or good afternoon from wherever you are listening. My name is Francesco Del Galdo. I'm Professor of Experimental Medicine in Leeds. I'm the chair of the Scleroderma Forum. This month's episode of the Forum series, it's about discussing two recent studies that were selected by our steering committee. And today I have the fortune to be joined by Dr. Elizabeth Volkman. She's Associate Professor of Medicine at the University of California, Los Angeles, and it's an eminence in the field of systemic sclerosis as a director of the Scleroderma program there. And with me, we'll read and discuss these two studies. I will go ahead with the first study, and this is a very interesting initiative of the World Scleroderma Foundation that was led by Dr. Campochiaro in Milan. And scleroderma, as most of you will know, among other things, as the burden of digital ulcerations. These are vascular manifestations of the fingers that are quite impactful for patients. They limit the hand function, they're painful at times. And of course, there have been studies trying to limit the impact of this manifestation on the life of patients. And while doing these studies, the community has realized that there is the need of aligning on endpoints, on definitions. And this is what this paper is about. It's about points to consider for reporting of digital ulcerative systemic sclerosis. It might look trivial, but when you go and look in detail, you realize there is a lot of things that we need to discuss. So the study, as I mentioned, was led by Corrado, and the objective was a working group of the World Scleroderma Foundation to establish how to standardize what to report in digital ulcers interventional studies. So with the precise objective of creating a framework, a consensus on what to report. So it was an expert consensus initiative, and it was supported by a steering committee of experts that it was convened by the World Scleroderma Foundation. And of course, it was supported by a systematic literature review. The World Scleroderma Foundation has been really stepping up, trying to implement a robust methodology like the ACR does, the Euler does. And so you see here in this slide, which is free to download for you guys listening. You can use it in your journal clubs, in your discussions. And first, there was a draft recommendation, then it was a committee review, and then an iterative email discussion with the consensus. Well, the results of the study showed that, first of all, as trivial as it could look, there is not uniform definition and classification of digital ulcers. So an ulceration of the digit can be defined in different places of the finger. Some people define ulcer only when there is a break of the epidermis, and in that case, some other manifestation like picting scars are not defined. So having a uniform definition of ulcers is crucial to be able to report or benefit of intervention studies. And then there are inclusion and exclusion criteria. Digital ulceration are typical of scleroderma, but they're also happen in other overlap diseases. And in these cases, including the presence of carcinosis, for instance, or excluding carcinosis may be quite impactful in the population and in the results, of course. And then, of course, the standardization of the primary and secondary outcome measures, including the PROs. We might focus on the diameter of an ulcer, of the number of ulcers, but what really matters is what patients think, the impact of these ulcers on patients. So integrating in the endpoint, the patient-reported outcome was deemed as a very important point by the steering committee. And the concomitant therapies, of course. We now have a lot more treatments available for digital ulcers compared to several years ago, thanks to the randomized controlled trials that they were done. And so being aware of the background medication is crucial to define the efficacy of add-on interventions. And of course, then there's a predefined timing and frequency of assessment. Digital ulcers are known to have a very variable time of healing. And so a study that has an endpoint at 12 weeks or 24 weeks cannot be compared to a study that has an endpoint at 52 weeks for the very nature of digital ulcers. And the other thing is important is that digital ulcers are, of course, an effect of the vasculopathy, and they are triggered by vasoconstriction, and which is of course the culprit of Raynaud's phenomenon. Raynaud's phenomenon is seasonal, and so also digital ulcers may have different behavior in different time of the year. And so trials in digital ulcers are very sensitive to the time of the year that they are run. And when you have a global trial, you may have winter in one hemisphere and summer in the other hemisphere, and that, of course, that is it can be an issue and needs to be considered. So the conclusion of the studies is that adopting a standardized reporting principle for future DU is crucial to add on the evidence that we already have. The only evidence we have now is on the number of digital ulcers, and that we have the endothelin receptor antagonists drugs have been approved. And by implementing a standardized framework, we'll be able to compare the results across studies. So it is a study that does not bring direct research data or new data, but is so important to standardize future outcomes. This was the paper. What do you think, Elizabeth?
No, thank you for that nice description. I think this is a huge area of unmet need. In the US, where I practice, we don't have any FDA approved therapies for digital ulcers. So it's very difficult to even get the endothelial receptor antagonist unless a patient also has pulmonary hypertension. And the cost of paying for this out of pocket can be prohibitive. So I'm hoping that if these can be implemented, there can be more clinical development to discover new therapies for this, because right now we're limited even in the ones that we use off-label. One of the things I found interesting was the selection of the primary outcome, and I was curious what you thought about this because they propose that the primary outcome be healing of an existing ulcer versus prevention of ulcers. But we know in many of our patients, they receive medicines that suppress their immune system, which could also affect the healing of the ulcers. How do you think this has to be considered in the context of a trial where there could be many factors that contribute to healing outside of vasculopathy?
Yeah, so I think you're right. The steering committee was deeply influenced by the current trials, but we already have a drug approved for new digital ulcers, whereas the evidence is a bit more lacking for healing. And the studies that have tested intervention like PD-5 inhibitors for healing did not reach statistical significance exactly because of the heterogeneity of background treatment. So I think it's a very important point. And it's very different in different parts of the world. In Europe, where we have available endothelin receptor antagonist, the current
Right,
unmet need is healing. But
healing.
defining this framework could help also maybe to repurpose or to do a new trial for a drug that we know it works and bring endothelin receptor antagonists that now have a very affordable cost through an FDA. So this could be just helping next regulatory trial in US with
Right,
bosentan, for instance, that is
sure.
a common drug. So you're right. Healing, I think, was influenced by the European adoption of ERAs for prevention, but
Yeah.
prevention in a country like US remains an unmet need. You're right.
No, that's great. And the other point that you made that I thought was excellent was the seasonal considerations and how to conduct these trials during a time when you're likely to have colder temperatures. But in the setting of climate change, and I understand it's been very warm in Europe lately,
It
I'm
is.
wondering if maybe instead of just choosing a season, having some way in the study to keep track of the ambient temperature, either through an app, could be helpful. And then that might not limit the time of year you have to conduct the study.
Yeah, no, you're right. Seasons have been changing meaning a bit. Yeah. So instead of season, maybe temperature, outside temperature. And now there are so many tools that allow you to put in context results. So that is an excellent point. So yeah, I think this paper shows that even for manifestation like digital ulcer that we have evidence, there's still a lot of room to improve the way we define endpoints and the way we build a framework for studies. And at the end will be an invite to people to run studies and to above all in a field where we know that there are some drugs that are effective because of previous studies. This could be an
Right.
excellent opportunity, right, for countries like US.
Yeah,
There you
that's
go. That's
great.
your next studies on digital.
Thank you.
And, and you know, to remain in the same sort of wavelength, the other study that was selected was very similar in purpose. It was about mycophenolate in limited.
Right.
Would you run us through the studies a bit and then we discuss it quickly?
Yeah, no, it's excellent. I don't know if you want to advance to the next slide, but this was a study looking specifically at people with limited cutaneous sclerosis. And as you know, most of the clinical trials that exist now for discovering new therapies for scleroderma largely target people living with diffuse cutaneous disease. But we know that people with limited cutaneous disease comprise two-thirds of our patient population. So we're excluding the majority of patients when we're doing trials nowadays. So that was one very positive thing about this study was it was particularly targeting people with limited cutaneous disease, exposing them to mycophenolate early in the disease course and looking whether mycophenolate could prevent progression of the disease. So another novel way of looking at things instead of just choosing one endpoint like a lung function test or a skin score, looking to see whether mycophenolate could be disease modifying. And so this study was conducted, it was multi-center, I believe it was in the UK, and really looking at feasibility of doing this type of trial where you'd have to assess events over a longer period of time and also look at safety and tolerability. And unfortunately, this study, I think, was conducted during the pandemic. So there were some issues with enrollment, which we experienced across all trials. So the recruitment was less than 60 patients. So they had to terminate the trial early. But there were a lot of lessons learned. I think that the medication was very well tolerated. So, in terms of risk benefit, this probably is a safe medicine to be using early in the course of the disease. And I think there needed to be more numbers of patients followed for a longer period of time in order to determine efficacy. But I do think this was quite an important trial in establishing the feasibility of doing a trial in people with limited skin disease and looking at prevention of outcomes. But I'm curious from your standpoint, what do you think would be like an ideal duration of this type of study, given that people with limited skin disease can sometimes have very slow progression?
Yeah, yeah, thank you. I think you summarized it very well. I'm a bit partial because I helped Chris a lot in the design and the conduct of this study. And I'm very glad to see the butterfly effect that this study had. Because first of all, yeah, the way we have been performing studies is inevitably influenced by the people running the studies and our colleagues in pharma, of course, often they are tight with deadlines and with short studies, and this
Right,
has in turn defined a population within our group of patients that tends to progress quicker quicker
right,
than others, and so where you could measure the effect of an intervention in a time frame that is compatible with their clinical development. And
right,
by doing so, we ended up focusing on 10-15% of our patients and disregarding the effect. So the work that Chris has done, first of all, it was based on an analysis of the Royal Free cohort, went back 10 years, and noticed that
right.
also patients with limited disease, give them time and they accumulate disability through
Yeah,
this time to clinical significant worsening. And then he adopted that for a drug that we know that without a formal trial against placebo, we know has been effective in diffuse. So the idea was brilliant. And I think this study is a landmark study because, first of all, it's shown that patients with limited disease, if you give them enough time, you can measure the effect of an intervention.
right,
And second, it start to spark the ideas that the endpoint can be a time to clinical significant progression. And we
right.
now have a phase 3 studies that has been actually is about to start next year that is
Right.
clearly inspired by this clinical progression. And
Right.
so it's a study that even if it did not show the effect on mycophenolate limited because this was a feasibility study to begin with. It was a study run
Right.
on charity funding, but had a great effect showing that yes, mycophenolate, that also patients with limited scleroderma have scleroderma. And so they could
Right.
benefit from an intervention. They can tolerate an intervention even during COVID times. And that we can start to measure systemic sclerosis not just from one point of view, from a digital ulcer or from skin fibrosis or from ILD or for PAH, but all together. And by doing that, we have a comprehensive view of scleroderma and we can have a real
Right.
defined drug. So it's really a landmark study that is I think is moving the field in the right direction of looking at this disease not as a compartment, not
Right.
as a one manifestation, but as a whole.
Yeah. And I think the questions will be, what is a safe duration of mycophenolate
Oh yeah,
therapy,
you asked me
given
that. Yeah,
that,
that
there is
question.
a risk of malignancy. So it's like if
Yeah,
we start our patients on it and they live
yeah, I
40,
got to
50
the question. You're right.
years.
Yeah, you're right. I didn't mean to dodge it, but the
Yeah.
thing is, it all depends on the sample size. Yeah,
Right.
because the time to clinical significant worsening, it's a very different consideration for sample size calculation because you're not based on patients, you're based on events. And so when you
Right.
reach a minimum number of events, you will have enough power to define the effectiveness of intervention. So it could be a relatively short study if you recruit hundreds and hundreds of patients, or it needs to
Mhm.
be a 2 or 3, 4 year study if you
Right.
are recruiting 1 or 200 patients. So I think it will the community needs to be ready for slightly longer studies.
Right.
I think here we suffer from the fact that we're rheumatologists and we're used to quick array studies where in 12 weeks
Sure.
we measure the number of swollen joints. And then
Right.
one day we start to think of scleroderma and we want to translate to this disease what we learn
Right.
in rheumatoid. I think this study has shown that we shouldn't do that really, and we have to look at scleroderma as a whole. And personally, I think it's also opened a new possibility of looking at the first manifestations. So the first time
Right.
that this manifestation occur, and so
Right.
they allowing us to target a population, the very early population,
Right.
that has all the biology of the disease, but they don't have the clinical manifestation yet.
Yeah,
Personally,
I
to
agree.
me, is the ambition of curing, preventing the disability of scleroderma rather than slowing down the progression of disease. I'm curious,
Right.
you mentioned the situation in US with digital ulcers. So if you wanted to prescribe today mycophenolate in US to a patient with limited, are you allowed to do that? How does it
Yeah.
work?
Yeah, I mean it's a very inexpensive drug, so that one isn't regulated to the extent that, something like nerandomilast is.
Yeah.
So it wouldn't be difficult to do. And, anecdotally, I've observed that many patients who I care for, who I, let's say, inherited from other doctors who have longstanding limited skin disease, who didn't have ILD, so they were never exposed to mycophenolate or any other immune suppression often end up with profoundly terrible GI disease, which has made me wonder that that was probably there from the beginning and may have been immunologically driven among other factors. That if they had been exposed to mycophenolate, they might not have ended up with this severity of GI disease. So I'm curious, like in a study like this, whether looking at GI endpoints might be
Yeah.
fruitful too.
Yeah, yeah, I agree. I was glad to finally see this study published because somebody should apply for a grant. This will never funded
Right,
by pharma.
right,
Somebody like us or somebody listening should apply for a grant to say, okay, to all the centers in US and Europe that you have these patients that you're
right,
not treating, why don't we randomize them to keep doing what you're doing or to give them mycophenolate open label? And then
right.
observe it 3 or 4 years, what happens? This could be a grant from an agency. Yeah, it could be the
Right.
NIH, it can be the ERC, it can be the Horizon 20, it can be a consortium, I don't know. And it's
Yeah.
something that I think it will be discussed at the SCTC because it's
Yeah.
clearly an unmet need. It's like we decided that limited scleroderma is not immunological and doesn't deserve immune suppression.
Right.
Whereas,
Right.
and then, as you say, I have exactly the same observation. These patients that did not have severe disease for years, did not have a diagnosis that supported an immunosuppression like ILD, you give
Right.
them time and they accumulate some disability. It could be in their joints, in the GI, or it could
Exactly.
be in their PAH. Maybe the reason why
Right.
PAH takes so long is the same. And if we treat
Yeah.
them at the beginning with immunosuppression, we'll never see PAH. So two
Right.
very interesting studies. I like the job of the steering committee of the Scleroderma Forum. And on this
Yeah.
note, I'd like to thank our steering committee, but most of all, Dr. Volkman. Thank you for
Thank
your
you.
time, Elizabeth. Thank you for all you're doing for the patient with scleroderma on the West Coast and internationally. And to you listening, guys, give us feedback, questions, ideas. We are here for you and stay tuned.
Thank you.
Thank you.